think we all run away if we see the nerve so closely and we fiddling the probe there. So, very daunting surgery that we saw. Sharish asked me to share with you my technique for a biceps tenodesis. I'll briefly explain to you why I prefer to do my tenodesis this way. We had a discussion on the slap repair. Thank you. And I wanted to share this technique with you because I've struggled with some of the other options we have. Just looking at why we're doing a tenodesis, obviously it's often in cases where we have degeneration, we have biceps pulley lesions, instability in the groove, and then of late slap lesions we tend to treat more aggressively by means of a tenodesis. I do a tenodesis or tenotomy in cases of partial biceps tear, any instability, irreparable cuff tears or massive cuff tears, pathological slap lesions, and atrophy of the tendon. Moving on, the considerations why I do this technique is time. I consider comorbidities, cost is a factor, risk of failure, and skill level. All of these factors play a role when you decide how you want to do your tenodesis. One of the things that I think is important is to consider the tension. As shown by Werner et al., under-tensioning causes deformity, muscle fatigue, and cramping, where over-tensioning you can get a failure of your fixation. So those are factors that I think is important when you decide on your technique. So different techniques have been described. Just briefly, open subpectoral techniques. You can use different methods of fixation. Arthroscopically, there's also been described different techniques. And then the soft tissue tenodesis has been reported, but is more of a historical value, not really recommended due to its failure rate in high demand patients. So where should we do the tenodesis? And looking at the different outcomes, comparing open subpectoral and arthroscopic, both have favorable outcomes, and the review article didn't reveal any technique to be superior. And just historical value, interference screw fixation. This is a technique that I've used in the past, and I've always been concerned of when I'm inserting my interference screw of a cutting of a tendon, and I've been disappointed that my tension isn't that good either. So I've moved away from this technique, even though studies have shown that this technique and the interference screw technique is a very strong fixation. So notwithstanding the fact of the strength of it, I still think the technique that I use. Looking at the suture anchor fixation, I think it's important to remember that we have cortical bone on the proximal humerus. So as soon as you go with a big 5 mm interference screw in this area, you have a risk of fracture. So if I consider this in a revision case or in a open case, then I will use a suture anchor. So in looking at the technique that I use, I just want to play this video. Sorry. Let's return. Is it possible to play that video for me? Thank you. So we have an arthroscopy of the right shoulder. We have our supraspinatus. I have my biceps tendon. I have through the Niviasia portal. I have a shaver that is used for soft tissue and bony preparation. This is an all intra-articular technique. What I try to do is I try to roughen the groove very high up in the joint to such a point that I have raw bone in the groove, and then I place my anchor. With that previous technique, I'm sure you noticed that the tendon is very close in proximity to my shaver, and so the risk with that technique is that you can shave your biceps, and I will show you an additional technique. if we play this video, once I've prepared my groove and I've inserted my suture anchor, I usually use either a metallic or absorbable screw-in anchor. I then pass the sutures in as Laurent has described, a lasso loop technique to fixate and to hold my biceps tendon. If you were to use a simple suture, you have a risk of a cutout. Now, the reason why I prefer using this type of technique also is I can place my sutures at the site of an anchor. And by doing that, I'm able to recreate the tension more accurately. Moving on to a different version. What we are doing here is you've got a left-hand shoulder. The arthroscopy is intra-articular. I've released the transverse ligament. We are looking down the groove of a biceps. I have my ablation device in an additional portal, and I'm releasing the full length of a transverse ligament. You can see you can sublux the tendon out of a groove. The reason why I want to do this is some of the studies from America have shown that if you leave a transverse ligament, this can be a source of pain. And of late I've been deciding to release my transverse ligament. What it also allows me to do is to remove my biceps from the groove and to allow proper preparation of the groove. I can now, through the same, I have an anterosuperior portal. This is more of an anterolateral portal. Through that portal I can bring my arthroscopic burr and I can prepare my bicipital groove. I can even deepen the bicipital groove, but I want to ensure that I have a bleeding bony surface. Once I've done that, I can then proceed inserting an anchor. I also prefer lately to use a screw-in anchor that allows bleeding from within the anchor site. I believe that assists, because the principle of this technique of mine is for me to try and have the tendon heal in the groove. So I fixate it with my sutures. You can see again a lasso loop, and then to attach it in the groove and for it to heal there. Some of you might wonder, but it's so high. It's been shown by studies by the Burkhardt group that tenodesis high in the groove in an intra-articular position has a low revision rate, low rate of residual pain, and have improved shoulder outcomes. But it's true, they have more stiffness, and despite that, I still find to have good results. But you can remember that you still have alternative options if you have a failure, but generally it's more stiffness that is a problem. The reason for this article is the controversy of supraspectoral tenodesis versus a subpectoral. Burkhardt and their groove use an interference screw very high in the groove. Looking at another option, I don't perform this, but there's an option that you can have from a bursal aspect. You have two anchors in the bicipital groove. You release the transverse humeral ligament, and then you can use all suture anchors in the hard bone here, and you can cinch the biceps tendon down. You decorticate the bone again, and you can use a double suture ankle. Costs for me in this case seems a bit severe. So the controversy is still there. Proximal tenodesis, high up in the groove. You have hardware. You have longer post-op necessary. You miss possible tunnel disease. However, I think we address this by releasing the transverse ligament, but the stiffness is a concern. The concern with a subpectoral technique is additional incision often, risk of neurovascular injury, and as I mentioned, fracture. So in my practice, I consider the patient demand, I consider his expectation, and of course the biceps condition. With my technique, if you have a frayed biceps in the groove, your technique or your fixation can be compromised. In those cases, subpectoral tenodesis technique is a good alternative. And in my patient population, the tenodesis, I do use it for my rugby players, the weekend warriors, the people who want to return to full fitness. And then, of course, cosmesis is also a considerable consideration. So my advice would be try and customize or be able to perform different techniques when doing a biceps tenodesis. Find a technique that works for you, considering your time, your skill level, as well as the type of fixation. And cost, of course, is also an consideration. And when you have made a decision on all of those factors, you optimize it, you try and do it repeatedly, and I'm sure you can get a good result. But as it is, consensus in the literature is not complete, and it's not final. Thank you, Mr. Chair.